Good evening. Dave Dargis. I'm one of the general surgeons here at Allegan General. I've been here since 1997, 16 years running. We do and I say we by meaning that Allegan Surgical Associates does a broad range of surgical procedures ranging from thyroid, breast, colon, hernia repairs, but we also integrate procedures for weight loss. And that's what we're going to concentrate on tonight and talk about. So what will we talk about tonight? Some of the trends and impact of obesity, what can be done to treat it, some surgical options, why the lap band system over some of the other options, the benefits, risks, patient profiles, and the affordability. In the past, obesity was viewed as a weakness or failure of the individual. Diet and exercise were commonly prescribed. But, and as well, weight loss surgery was viewed as very risky. At present, we see that obesity is more a disease with some serious relative health effects. Diet and exercise remain the cornerstone of the treatment. However, surgery is accepted and proven treatment for it. And we'll go over some statistics here down the road here. And surgical treatment is certainly appropriate, but you have to qualify for it. And we'll go through some of those qualifications. What do we mean by obesity? Let's talk about some of the definitions. And you see pictures here depicting someone who's overweight versus obese versus severely obese and morbidly obese. And we talk about a number called a BMI, body mass index. And we see in the obesity category, it's a BMI of 30 to 34, severely obese 35 to 40, and morbidly obese over 40. This is a somewhat complex table, but it's simply put, rating your height with your weight, and then you come up with this calculated number. And categories that we, again, talk about are these three, the obese, severely obese, and morbidly obese. We see that with weight comes disease. Disease in the form of diabetes, high blood pressure, sleep apnea, depression, joint pain, cancer, GERD, asthma. And we can see from this graph that as you get heavier, and in particular, that BMI of over 35, that the incidence of sickness greatly increases. The impact. What are some of the economic impacts? We see that there's a social impact of how you appear, the clothing, weight-related medical costs increase significantly as we get heavier, and medical spending does as well. How do we evaluate weight loss? When we talk about how much weight we're going to lose, we talk about excess weight loss. And that is the excess weight that you may lose over the amount that a patient carries over their ideal body weight. In other words, it's your ideal body weight, what you weigh minus your ideal body weight. Excess weight loss refers to that amount of excess weight that is lost. And we use this term somewhat commonly, so it's something to familiarize yourself with. What are some of the strategies out there? What do we talk about? Where do we start? Dietary intervention. You can anticipate about a 10% reduction in your body weight when we talk about diet. Now understand that diet in and of itself, of all the diet-related programs that are out there, statistically speaking, only about 2% will be successful 2 years running. And if you add them all up, Jenny Craig, to everything you read on the magazine stand, only about 2% of diets out there will be successful. Physical activity doesn't always lead to weight loss. Behavior modification really is required for whatever approach that you choose, there needs to be a cognitive, a thought-out process that you're ready to lose weight. Drug treatments. Typically, these are short-term regimens. They sometimes are dangerous. They're oftentimes not FDA approved. So caution here. Weight loss surgery. It is the most effective approach to weight loss. I'm going to go through some statistics that prove that. Let's talk about ghrelin. This is a peptide hormone produced primarily in the stomach and in the proximal small bowel. It powerfully stimulates appetite. Okay? We look at animal models here. In ghrelin, and I emphasize, diet-induced weight loss. Okay, when we go on a dietary program, we follow the Jenny Craig or the grapefruit diet, whichever one you choose. In animal models, we see an oscillation or an up and down of this ghrelin molecule. Remember, ghrelin equals appetite. So as we go through these diets, as we progress through them, we see an up and down of the ghrelin molecule. Well, what happens to your appetite? It goes up and down as well. So there's oftentimes a yo-yo effect. What happens to ghrelin molecules after bariatric surgery? There were no meal-related ghrelin oscillations in subjects that underwent surgery for weight loss. In other words, you don't see that up and down. And your appetite subsequently doesn't go up and down. Without changing any other lifestyle habit, lap band, what happens when we take the lap band out? Okay, guess what? Ghrelin molecule activates again, and we see a significant increase in weight, upwards of 4 to 5 pounds, when we take the lap band out. So how do these, what are the surgical options and how do they work? We're going to talk about essentially 3. The lap band, the gastric bypass, and also the gastric sleeve. So let's talk about each one of these individually. This is a little depiction of the gastric bypass and how it's done.
Gastric bypass is a restrictive and malabsorptive procedure that results in fewer nutrients and calories being absorbed. It reduces food intake by cutting and stapling the stomach to make a small stomach pouch. The small intestine is cut and the lower section is directly attached to the new pouch. Food then passes directly into the lower portion of the small intestine, bypassing most of the stomach and upper intestines.
Again, a permanent procedure, very difficult to reverse. Let's go through the gastric lap band.
Sleeve gastrectomy is a restrictive procedure that limits food intake by cutting and stapling a thin vertical section of the stomach to make a smaller, narrower stomach pouch. The remaining larger portion of the stomach is then permanently removed.
Permanent cut here.
Unlike gastric bypass, there is no rerouting of the intestines. However, the sleeve gastrectomy involves permanently removing a large portion of the stomach.
And there's a lot of debate in the European literature versus the U.S. literature on how large, how small we make the stomach, how much reflux disease there is after the procedure. So a lot of controversy. Let's talk about the lap band. It's performed laparoscopically.
During a minimally invasive procedure, an adjustable band is placed around the upper part of the stomach, creating a small pouch. The band is connected by thin tubing to an access port below the skin. Through this port, your surgeon adjusts the lap band by inflating or deflating the inner lining with saline. As the band inflates, the stomach outlet becomes smaller. This helps reduce or restrict the amount of food you eat and slows the emptying into the lower stomach, helping you feel full sooner and stay full longer.
So what happens ultimately when we have a surgery? Then let's compare the gastric bypass with the lap band. We see weight loss in the first 12 months, significant weight loss. In fact, there's more weight loss with the Roux-en-Y gastric bypass than there is with the band. But ultimately, over 2 to 3 years, that equals out a little under 60% excess weight loss. And this is very safe and effective weight loss with the lap band. With the lap band system, we see a significant improvement and or resolution of multiple medical problems, including asthma, hypertension, diabetes, sleep apnea, and reflux. But the numbers are quite impressive here. Upwards of 75% of patients are able to discontinue medications related to their other medical problems after they've acquired that excess weight loss. The data is so strong and convincing that the American Diabetes Association made a recommendation that bariatric surgery should be considered for adults with a BMI of over 35, especially if their diabetes is difficult to control with diet. So, what other impacts do we see when we lose weight? This is a study of over 15,000 bariatric patients, 7-year follow-up. And if there's one take-home point that we can make tonight, there's upwards of a 40% reduction in mortality. Okay? 40% chance, improvement in the chances of reducing death. And what are those causes of mortality? There's a 56% reduction in cardiac disease, 92% reduction in diabetes, 60% reduction in cancer. If this were manufactured as a magic pill, it would be the most popular pill ever made. What are some complications? Why have I chosen the lap band over the other two? I practice in a small community. I don't like to take risk. I don't like complications. This is a very large study of over 22,000 patients, 30,000 in here, and over 1,300 with the sleeve. And you can see here that the gastric band, albeit there are complications with it, is significantly less than with the bypass or sleeve. 17% with the sleeve, 24% with the bypass, only 6.3% with the sleeve, or with the band. Greater than 1 complications, again, we see a reflection of the same kind of numbers here. We can see that the safety outcomes with the band are somewhat comparable and much better than the other two options. So what are the complications with the gastric bypass? Pulmonary emboli, leak, hernia, ulcers, bowel obstruction, mineral deficiencies, and dumping syndrome. If you know of anyone that has had the gastric bypass, and talk to them about dumping syndrome, it's very socially embarrassing. These other complications can be life-threatening as well. So not only are they complications, but they're serious complications. 24% had at least one of the above complications, and that was a study of over 30,000 people. With the sleeve gastrectomy, complications, leaks, stenosis, suture line bleeding, incisional hernia, and reflux. 17% of patients had at least one. Again, very limiting and potentially life-threatening complications. What are they with the band? 6.3% of patients will experience at least one, but let's break them down. Band slippage. If the band slips, and I will depict that in my hand here with the bottle. By slippage, we mean the band rotates up or down, typically down, and this pouch becomes larger. How do we treat that? We desufflate the band completely, and in upwards of 60% of cases, the band will rotate back into its normal position. Band erosion, very highly unlikely. It can happen. If it does happen, we unfurl the band and simply take it out, allow the stomach to heal. Stoma blockage, again, very unusual, and vomiting typically will be treated by emptying the band relieving some of that pressure, making the lumen a little larger, or that passageway a little larger, and that typically will take care of that problem. But again, a low number relative to the other options. In the length of stay, days to normal activity, length to recovery, we see a significant improvement in those number of days as far as the recovery goes. Sleep gastrectomy, not a lot of large studies available. So, four reasons why I chose to provide the band for those patients here in Allegheny County. It's proven safe. It leads to a significant excess weight loss. It's quality weight loss. You don't see the mineral and vitamin deficiency disorders that we see with the room like gastric bypass, and it's sustained weight loss. We keep the weight off over time. There's a high satisfaction rate. Upwards of 94% of patients that have had the lap band done are happy with it. How about the cost? How much money are we going to save per year? Let's break it down. Mean medical drug costs with a BMI over 35, $7,000. Out-of-pocket healthcare expenses, your HSAs and other co-pays, $2,600. Inactivity costs, $1,100. Commercial weight loss programs you may have tried and failed, $600. Prescription co-pays, $700. Food, almost $6,000. So overall, $18,473 a year, per year, cost saving. How have we done in Allegheny relative to the national average? We pride ourselves in that we are above the national average 12 months running in the excess weight loss that our patients have accomplished. The national average is about 40.5%, and we're at 40.9%. And Chris does a very nice job tabulating and maintaining that data. These are two patients. Haley was on death's doorstep here on home oxygen. Her family practice doc simply told her that if she wasn't going to lose some weight, she wouldn't be around for much longer. It gave her enough incentive to undergo the lap band. She is one of our poster children. She is phenomenal. Well, until tough with these two pictures here, she's lost a tremendous amount of weight. Phyllis is another nice example of a similar scenario. She happens to be the operating room coordinator. She works here at Allegheny General Hospital. So she is a very nice resource for us. So how do we qualify? Who qualifies? You have to be at least 18, 30 pounds overweight, or a BMI of 30 or higher, and have other medically related problems, or simply have a BMI of 40 or higher. You have to have some documentation in some insurance programs of attempted weight loss strategies, and you have to be screened for other disease processes that may lead to weight gain, such as thyroid disease. We have to be prepared to set lifetime goals, and we have to be willing and able to come back to follow up. We are going to be tied at the hip, if you will, for a lifetime. And you have to understand that literature that we provide you. Make sure that you read through it, understand it, and ask questions if you don't. So what do we have to do beforehand? How do we get to surgery? We have to have a psychological evaluation, typically by a psychologist. Nutritional evaluation, Chris, our program director, would provide us with that. Medical evaluations, lab work, that will be tailored to your specific medical problems. A GI evaluation with an upper GI. Let me step back a little bit and talk about this. In patients with a BMI of over 35, there's about a 50% chance you have what's called a hiatal hernia, meaning a loosening of the muscle between the esophagus and the stomach. If that muscle is loose, that needs to be fixed or repaired while or before we do the lap band. So it's something we would talk about beforehand And it's something that we can easily adjust in the operating room if we know about it beforehand. So that's why typically I will order an upper GI, especially if you have any reflux symptoms, regurgitation, heartburn, etc. Sleep apnea screening, pulmonary function test, cardiac testing, that is specific to your medical problem list. So what are the next steps? I'd like to entertain any questions. Chris will be up to talk about the Lap Band Journey website. We'll talk about insurance coverages, consultations, etc. And that essentially concludes our program. And I appreciate your attention.